Welcome to Orthonote. So today we would like to discuss about the lateral condyle fracture of the distal humerus. So as we know that the lateral condyle is an origin of the common wrist extensor. The etiology is trauma, and it actually affects the 2 to 3 years old, with a second most common injury over a pediatric orthopedic cases. And the mechanism of injury is usually a pull-off mechanism or avulsion because of the common wrist extensor origin. And the anamnesis and physical examination, as we know that the patients of pediatric patients can come with a swelling, history of trauma, and also tenderness over the lateral condyle of the humerus. The supportive examination that can actually be done is the X-ray with a 3 views, the AP view, lateral view, and internal oblique view. The internal oblique is usually to see a displacement. So the Rockwood children books say that it is necessary for us to see the internal oblique view of children with the suspected lateral condyle humerus fracture. The classification, it actually depends on some areas, so it is divided into based on the anatomical location, in which the classification in Milch classification, and then the second one is Jacob for the stage of fracture displacement, and the last one is Song with fracture displacement and fracture pattern. For the anatomical location, Milch, it is divided into two, so whether the fracture is crossing through a capitular ossification nucleus or not. So if the fracture is going through the ossification nucleus, so it is considered as a type 1. Meanwhile, if it is around the capitular ossification nucleus, it's considered as type 2 Milch classification. For the Jacob stage of the fracture displacement, it is divided into 3. If it is less than 2 millimeters, so we consider it as a type 1. If it is more than 2 millimeter with an intact hinge of the cartilaginous, it is considered as type 2. Meanwhile, if it is non-intact hinge, it is considered as type 3 Jacob classification. We move on to the last classification, the Song classification, which is depends on the fracture displacement and fracture pattern. So I remember it from the stage 3. So if it is already in if the fracture is already going through the metaphysis and going through the epiphysis, so it divided the distal part or distal fragment into a lateral and medial fragments, so it is considered as a stage 3 Song classification if the displacement is less than 2 millimeters. And as you can see here, if it is already rotated, then it's considered as a stage 5. Or if it is less than 2 millimeters and it's metaphysis only, it is considered as type 1 or stage 1. The treatment divided into non-operative and operative, and it is depends merely on the displacement of the fracture. So if it is less than 2 millimeters, we can treat it non-operatively with a posterior splint or long arm cast with a 90-degree elbow flexion. Meanwhile, for those patients with a displacement of more than 2 millimeters, or those who can actually be treated with a close reduction, with an anatomical reduction over the fluoroscopy, we can do a close reduction and percutaneous pinning. In addition to it, with a posterior splint or 90-degree elbow flexion, as stated here in the in my notes, I get it from Google. So the pictures, so whether we can do two or three divergent K wire or one cannulated screw. Other than the CRPP, if the displacement is more than 2 millimeters, if it is displaced and unstable and then with malangulation and malrotation, we can treat it with open reduction and internal fixation. The usual approach that can be done is a lateral approach, or so-called the Kocher approach. Here we can see that we can incise it through the middle of the lateral condyle onto the lateral side of the radial extension to the lateral to 6 to 8 centimeters to the proximal or distal part. It depends on anatomical position. As we know that to decrease the possibility of injury of the posterior interosseous nerve, we can move the elbow into a pronation. And so this is the Kocher interval. We do the incision between the extensor carpi ulnaris and also the angonius. So Rockwood stated clearly, so for an acute lateral condyle fracture, it depends whether it is a non-displaced or displaced, and for the non-displaced one we can do a long arm cast. Meanwhile, for the displaced fracture, we need to see it from the fluoroscopy whether it is stable or not. If it is stable, we can do close reduction with percutaneous pinning, or if it is unstable, then we can move on to the open reduction. For the complication, it's divided into early and late. So for the early complications, usually it's just a transient radial nerve palsy. Meanwhile, the late, it is divided into some conditions. It is stated in the Rockwood. Well, the usual thing that might happen, one of the most well-known is the tardy ulnar nerve palsy, in which it's usually because of the cubitus valgus. And then other than that, you can state it here. You can read it by yourself. And to be noted that I just want to remind us about the Perkin-Stein table, in which the non-union is stated if it is not unite after 12 weeks or 3 months. For the treatment of the complications or the non-acute lateral condyle fracture, if it is more than 12 weeks, then we can see whether we can do open debridement, bone graft, and ORIF for a non-displaced one, or for the displaced one we can do define whether there is a tardy ulnar nerve palsy or no tardy ulnar nerve palsy. It is simple or more simple if there is no tardy ulnar nerve palsy, so we can just do an open reduction, bone graft, and supracondylar osteotomy. As we know here, the lateral close switch supracondylar osteotomy.